record on the computer. Okay, so we'll talk today about different picture of shock, but we'll take the preterm baby because that's often something that we have a lot of trouble at the bedside trying to understand just because they have a very immature organ system and they may be subjected to different phenotypes of shock-like pictures. And often, when they start decompensating in front of your eyes, you want to try to understand, well, do I need to give fluid? Is it neck? Is it a problem of RV or LV dysfunction? Is it my PDA that's causing this phenotype? Or do I have extra cardiac elements that may contribute to the hemodynamic instability of these patients? So I think a lot of the core applications we do in the acute setting in TNE is to try to understand why your baby is becoming hemodynamically unstable. Of course, there's a whole component of the patients who have, various pulmonary hypertension phenotype, more on the chronic phase. There's patients that may have cardiac hypertrophy. So there's definitely elements that we try to understand. But today we're going to try to deconstruct kind of the main picture of what shock is and how it can present in the early period of life or during an acute event of decompensation. So let's skip this. I think by this time you know all the cardiac views because you've been scanning quite a lot. And you've seen this morning a perfect example of a PDA and how it looks like when it's wide open and completely left to right. So we'll start by a case. You have a 25-week-old girl. She's born in context of maternal preeclampsia, so there was no history of like infection risk factor. It was really for maternal reason. And potentially an adverse placental environment. This baby is now 24 hours old on CPAP. Minimal oxygen, occasional events, caffeine has started, CO2 is fine, pH is fine, lactate is fine, hemoglobin is fine. For some reason, someone did a head ultrasound, which is normal, which is not even something that we would do in our unit. And then the kid is peeing well perfused, is active, has a good heart rate, and you're called because your blood pressure at 24 hours of life is 27/17 with a mean of 19. So first of all, would you get excited about this in your unit?
No.
Great, love it. What would you do for this patient?
Um,
Like nothing, ciao bye,
can I just
resident called, ignores the
no,
patient,
can you
written in the note of the nurse.
tell us what's the fluid status of the baby in terms of how much is he receiving and so on, or do we know that?
Yeah, that's a good question. So the patient is currently on 80 cc per kilo per day, and it's peeing about 3 cc per kilo per hour. So about 70 cc per kilo per day of urine output. So already it's been increased to 100. Let's say it's been bumped up.
And
Okay.
so the weight is
And
not like 20% down.
no, so the weight, the patient lost 10 grams.
Well,
Mm.
the baby is 24 hours of life. I'm gonna say that your pressures are soft, but it looks like you're hemodynamically stable. Your lactate is low, your urine output is okay. Maybe just probably just trending creatinine and stuff like that, and just see where we go.
Love it.
Do an
So I
echo.
fully, yeah, we could consider doing an echo. I think that when I was younger in my practice, I would have definitely jumped to do an echo. I think in many places they would do an echo, and I'll show you the echo. But I think if the patient is well and transitioning well, I think I would clinically, personally nowadays, I'll be fully honest, I would probably just continue monitoring very closely. We also have these now population-based blood pressure that we try to use at a Canadian scale, which you can see that, at 25 weeks, your mean should be around 20 for the fifth percentile. So maybe it's a bit like soft with a, systolic of 26. So here you're above and your diastolic of 17, which is just on the cusp. So, my assumption of this patient is that probably this patient is going through, a drop in PVR. There's transitional physiology, and there may be a PDA that's open there somewhere, and it's causing a steal effect, especially knowing that this baby might have been a bit IUGR and SVR. The SVR are probably a bit stiffer than the PVR, so there might be more of a left-right shunt at that point if the PVR have dropped. But in any case, we are, someone is a bit concerned and decide, could you please give me a sense of what's happening with the cardiac function? I'm worried there might be a hypertrophy. I'm worried there might be like pulmonary hypertension, even if the patient is on 23%. And, most people, when I surveyed, actually, they would do a TNE. And if you would switch and provide like elements like, being gray and cold and clamped, of course, then, a TNE would provide you a lot of information. But you do a TNE and what you see, I'm just showing you like some of the classical views. So we're not going to go through all of the output calculation and PD and all these things. This is a patient that, sensitively has normal LV function, normal RV systolic function, around septum and systole. You do a PDA cut. There is a PDA. It looks, small to moderate in size. It's left to right. It looks unrestrictive. And you consider that this patient may have, some transitional physiology and maybe a bit of ductal steal. So I think for me in these patients, my approach, and I'm not sure it's the right one, we know more and more that there's trials being done trying to better understand how to address these numbers. But for these patients that are clinically well, that have no signs of end organ hypoperfusion, that on TNE have appropriate cardiac function, appropriate outputs, and that have good urine output. So even if there's a steal effect, they're not in acute kidney injury, they're able to perfuse their kidneys. We typically will use these tables not necessarily to guide what is normal or abnormal, but really to guide the nurses at bedside to call us when there's something that should be a red flag for us to do our further evaluation. But you need to take into context all the whole package. It's not just the number of the pressure, and we'll talk about why it's not just the number of the blood pressure. That's the first thing. The other thing is that, these patients may have very dynamic blood pressure. And of course, the patient who's been like 5 days with blood pressures that are, systolic in the 30s, 40s, or, and mean blood pressure in, 28 to 30, and then suddenly you get something that tanks and you get a change in your clinical picture, then obviously that's a bit more worrisome than a patient that is transitioning and is obvious and otherwise asymptomatic from a cardiorespiratory standpoint. So if we go back to physiology and try to understand some of our patients at bedside, when we talk about shock, we talk about the idea that you're not matching basically the delivery of oxygen and nutrients to what your tissue is supposed to get for its demand. So your factory needs that amount of material to produce Toyotas. You're not able to produce the Toyota. The factory is going to go and close, right? It's not going to work. You're not going to get cars. So, and sorry, I don't have a Toyota. I don't want to make a publicity for a specific company. But, the idea is that, you have a bank. You have either money or no money in the bank. If you have no money in the bank and you try to go buy a house, you're going to bankrupt. So it's kind of that concept of you need to deliver, and that delivery is actually complex on its own end. And then you need to have your tissue being able to handle the oxygen and handle the nutrients and being able to match its demand for the cellular function to work and not eventually get ischemia and cellular death. And so we know that, for example, in E. coli sepsis or gram-negative sepsis, one of the components of this disease is not just the delivery, but it's actually at the level of the cellular function where mitochondria can start shutting down and they're not able to handle some of these oxygen and nutrients. And that's why the cell starts dying or becoming reliant on anaerobic metabolism, because the whole cascade of the Krebs cycle and all these things is being inhibited by LPS surge. So, and then on the perfusion end, we're going to have to see what could be affected that us, neonatologists at bedside using hemodynamics, we could potentially manipulate to at least address that component. We know that patients in shock, there's a component of demand. So sometimes when you have patients with severe cardiac dysfunction, you may actually consider acting on the demand side of things. So decreasing your demand, decreasing your seizure burden, making sure your patient is quiet, avoiding feeding the patient because that requires energy for metabolism, making sure the patient is ventilated or supported in terms of ventilation. So it's a bit of the treatment of like heart failure where you have to address both the delivery, so the motor is a problem, you don't have enough flow in your tissues, and then you have the demand of the tissue that's exceeding what you're able to achieve. So you're looking at all these components when you're looking at a patient that's actually decompensating. So we went over the clinical presentation. You guys know it. At the bedside, many of these markers can be very imperfect, and it's just not one single marker that will inform you on the physiology. So typically we'll look at obviously the blood pressure, which is one of these markers that our nursing team will be monitoring and calling us when there's values that might be a bit more worrisome, such as either an absolute value that's under some of the thresholds that you're giving as a red flag to be called and assess the baby, as well as some of these trends. Now, we know the blood pressure is a function of resistance times flow. And so you may have a lot of resistance and very low flow and have normal pressure in your tissue. You may have very low resistance and a lot of flow and have normal pressure. You may have very low resistance, very low flow, then your pressure starts tanking. You may have, trying with resistance to increase, but the flow is just not compensating. So, your pressure might start tanking. So it's kind of these things that you need to assess at bedside. And looking at the systolic diastolic mean, sometimes they're pre and postductal. If you have an arch obstruction or arch interruption, it can also inform you on some of these things. Heart rate, typically, most of the babies will increase their cardiac output by acting mostly on the heart rate and a bit on the inotropy. We talk about the force frequency relationship, where increasing heart rate will typically also increase your inherent capacity to contract. There's a limit to that, especially in preterms. And obviously, as you increase your heart rate, you have issue with filling time. And so then you can impair how much your filling is happening. And that's especially true for patients who have like inherent hypertrophy of their ventricle, where if they become very tachycardic as a response to the low perfusional state, this may really reduce their filling time, and they already have difficulty filling because they're hypertrophied. But the problem with heart rate is that it can be influenced by so many factors, and our babies that are born preterm may not show a nice response to heart rate, in the sense that they may have autonomic nervous system dysfunction. They may have seizures that are ongoing if it's an HIE or they had asphyxia, or sometimes their heart rate may be affected by other factors. So capillary refill time, very subjective. We'll tend to look at the central areas. And obviously, if you have kind of a low SVR state, you'll have a very brisk capillary refill time. But meanwhile, it doesn't mean that your patient is well perfused, because there may be actually a very low perfusion pressure because the SVR is so low, and the heart will try to accommodate with increasing the flow, but at some point it will not be able to accommodate that. Pulses on physical exam are important. We know that they represent actually the pulse pressure. So it's the difference between your systolic and your diastolic. So you can have a very low systolic, a very low diastolic, but the gap is very high. And you're going to have great pulses, but meanwhile, your baby has a lactate of 12. You can also have a nice systolic because the LV is trying to maintain the upstroke into the aorta, but a completely ruined diastolic because there is a steal somewhere, like AV malformation, PDA, all these things that causes a steal. And then your patient can also be very profoundly hypoperfused because of that, despite having good pulses. And if you're on actual pump that is uniphasic and not flow generated, not pulsatile. Like, for example, Berlin heart is like a ventricular assist device that has a mechanical pulse, basically. It's a pneumatic pulse, if you've seen a Berlin heart. And so these patients will have a pulse. But there are VADs where they're not pulsatile. And so these patients don't have a pulse if their inherent heart is not able to generate a pulse. But meanwhile, their perfusion pressure is very nice. So you have to be aware of these things when you're assessing your baby and put all of this together. Cold to touch model, that's true in patients who have typically a high SVR status. This can be fooled if you're, for example, on cooling, where you're actually inducing a cold status. Abnormal body temperature, well, we know in our preemies that they have difficulty managing their own temperature. So if, of course, they become hypothermic in an excessive way, that could be a sign of concern. Hepatomegaly is an important factor to check in patients who may be at risk of RV dysfunction, because it's a sign that there's high RA pressure. And so you can have hepatomegaly if you have very high MAP on your ventilator, or if suddenly your RV is failing and your RA pressure starts rising. Of course, all these other things we mentioned may actually be markers that are a bit too late. So urine output means your kidney are already affected. Apnea brady's may mean that you're already affecting your cerebral perfusion. Lactate, it's also a marker that there's already ischemia ongoing, but sometimes lactate buildup can happen just because you had placental insufficiency and your tissue were dependent on anaerobic metabolism during fetal life. So sometimes the lactate in the first few hours for some of these babies may not be the kind of best representation of whether or not there's nice perfusion at that point. So pressure is flow times resistance. If we translate that into the full system on the systemic side, it means that cardiac output times resistance gives you a blood pressure. Typically, we also add the draining pressure. So here that would be the right atrial pressure. We know the right atrial pressure is typically quite low, so it's 0 to 5 millimeters of mercury. If you look at the blood pressure in the pulmonary arterial compartment, it's the same thing. It's RV output times the pulmonary vascular resistance plus LA pressure. The blood pressure is typically pulsatile. You get a systolic and diastolic phase. And so you get the systole, you get a dicrotic notch, and eventually you get your diastolic, which is the lowest point. And then you restart your cycle. And really the mean is the area under the curve. And so the complexity we see in many newborns is that we have these two circuits that are often connected by shunts. So that may also affect some of these readings of systolic and diastolic pressure. We know if there's a large PDA and there's low PVR relative to SVR, then you can have a lot of diastolic runoff and your systolic upstroke may try to adapt, and that's why you get a higher LVO. But you may not adapt sufficiently. And some of these steal effects, depending on the lesion, like truncus arteriosus, will not be able to adapt. At some point, it will start having hypoperfusion to the organs. So cardiac output is a function of stroke volume times heart rate. The stroke volume is impacted, as you know, by contractility, preload and afterload. Preload is what you're filling your atrium and your ventricle with. Afterload is the load at which this pump it needs to bench press against. And contractility is that inherent capacity to contract. And so I've put a list of different things that can affect contractility, preload, and afterload. But I just want to remind you that anything you do on a mechanical ventilatory elements, anything that's intrathoracic, so if you have a pneumothorax, tamponade, or large pericardial effusion, all these air trapping or pleural effusions or chylothorax, they may all impact your cardiac dynamic, either by changing your preload, but also by affecting the afterload. So for example, your mean airway pressure of 20 will increase afterload on the RV, and it may really decrease your LV preload because there's just less pulmonary blood flow going through the lungs because all these alveoli are squished, or at least the vascular component inside the wall of the alveoli is squished. So it's not able to get as much nice preload coming back to the LA and eventually the LV. Heart rate is the main compensatory mechanism of most babies, except if you have other issues that may impact heart rate. So you may be already on medications that are affecting your heart rate, like chronotropic drugs. So for example, if the kid is on beta blocker for some reason, or accelerating the heart rate if the patient is on dobutamine, or high dose, norepi or epi or dopa will, have some chronotropic effect. And then there's obviously, as we said, autonomic nervous system function. The resistance, we often look at the resistance like if it's one single thing, but there's like a total peripheral resistance, which is the sum of all these resistances. And that can be impacted by inflammation, again, autonomic nervous system. So if you have ongoing seizure, you may have vasomotor instability. If you're giving medications like fentanyl, pheno, phosphatidylcholine, and all these things, you can affect also your resistance in some of these organs. And of course, if you're deficient in certain steroids, in certain hormones like steroids or even thyroid hormone, you can have issues with that. And there are certain medications that will mess up with your total peripheral resistance, like think of milrinone. It will cause a drop in your SVR. Some of the pulmonary vasodilators that you administer intravenously will also affect your SVR. So you have to keep that in mind. We don't talk about it often because it tends to be stable, but viscosity can affect a bit your resistance too. And, all these PDAs are not necessarily equivalent. So you need to compound this, that when the PDA is open, these ventricles are often seeing a common peripheral vascular resistance because you're connecting the two boxes together. So you've seen this landmark trial, which was not able to, unfortunately, recruit its expected target, which was trying to answer the question about whether or not we should be treating these patients with isolated, quote unquote, hypotension, so low numbers, so these preterms that have BPs that are kind of low. Very arbitrarily, it's like the GA that's been chosen as a number to consider a low BP. Again, a low BP means really nothing. You have to assess what's happening on the resistance and flow patterns. But this study tried to, see if whether starting dopamine versus placebo would lead to differential effects on outcomes. And so more and more, there's actually been a push in the literature to avoid exposing these patients that are very vulnerable and ongoing transitional physiology with no signs of hypoperfusion. There's been a push to avoid exposing them to cardiovascular medication because we know that they have kind of this undifferentiated effect throughout the systemic vasculature and pulmonary vasculature, and they may lead to more side effects and actually benefits. And so, unfortunately, they were never able to get to the planned recruitment rate. There was no difference in survival without brain injury, but they only had 8% that they were able to recruit in this study. So this is a study you need to know, you need to read about it, and you need to understand its component. Actually, Dr. Dempsey is our Robert Usher lecturer this year at the Montreal Children and McGill. So low numbers of EP does not mean low flow, and premature infants will often have dropping numbers as the PVR will drop if the PVA is still open. And as I just mentioned, some of these inotrope vasopressor will have side effects and toxicity and may affect also cerebral vasculature. And so in that sense, we are tenants that if there's no signs of clinical hypoperfusion, the cardiac function is normal, the flows are good. And so in some of these patients that have persistent low BPs, like the first case we mentioned, before jumping onto medication, it's definitely a patient I would get like a TNE to better understand what's happening. So we spoke about this textbook at the beginning of the year. Dr. Rudolph is a fantastic physiologist. I think he's like the father of understanding physiology. And basically what he said is it was suggested that the level of mean arterial blood pressure that can be considered to be normal is equal to the GA in weeks. And this is somewhat arbitrary and has not been confirmed in any reliable observation. So I think that's quite important to remember when you're seeing these babies and you're being called for low numbers. But to speak the same language, we did provide to our nursing team values at the 5th percentile, which you can see, like, for example, a mean that was less than the 5th percentile for a 22-weeker would be considered 17, 18, 23-weeker, 19. So it's not really that, 22 or 23 or 24. So we're much more conservative in terms of when we want to be called. And there are patients at 25 weeks that will have quote unquote numbers that are looking normal and they're actually not doing well. So that's important to keep in mind. And that's where hemodynamics helps you. So I've put for you here some of these important trials that have been done on looking at solely the whole idea of hypotension or low blood pressure, whatever that means, and how, really most of these trials have not yielded in any kind of meaningful improvement in outcomes and actually shown potentially more side effects than anything. So what's our approach to management when we try to tackle this with the hemodynamic standpoint? A lot is based on the physiological assumptions, observational data, and what we would expect to be the effect of the medication in that particular setup. So that's a great paper by the late Regan Gitzinger. She looked at, okay, what if you have these numbers that you would consider in your unit to be low in the systemic compartment? And what is actually the number that you feel is concerning? Is it the systolic, diastolic, or both component? And at that point, do you consider that it could be low LV stroke output or decreased stroke volume from your cardiac output? Is it a question of low SVR, which explains why your diastolic pressure are dropping? So you can think of a patient who has the systemic vascular resistance is connected to the PVR. If the PVR drops, it's like kind of the combined vascular resistance that are dropping, or is it both? And so at this point, you have a component of both elements. And based on this, you can go down your algorithms and try to see how would you tackle for management. But how I will try to divide it is a simplistic matter. You will see that throughout the year, we'll go through kind of more in depth of these phenotypes and trying to understand which medication we start, how do we start it, how do we wean it, what are combination we should consider. And obviously, when there's like a dynamic change in the phenotypes and physiology, how do we remove these things and we reevaluate our patients? So if you think that you have a primarily issue to your pump, and here I'm going to concentrate on the LV, but it could be true for RV as well. You have to think about some of these elements. So could there have been a component of poor perfusion to your LV? So I have hypoxia, coronary hypoperfusion, an asphyxiated event, which really impacted your left ventricular function and perfusion. Typically, you'll see that it's, they can get segmental also anomalies because of hypoperfusion, some areas that are more ischemic than others. You do have to still think that this might be secondary to RV failure. So there could still be something like pulmonary hypertension, high PVR, RV is failing, and it's also impacting your LV. Could there be a primary cardiomyopathy? So some of these patients, will be born and they have like a genetic disorder and they have like Noonan, hypertrophic cardiomyopathy, dilated cardiomyopathy. They can be infant diabetic mother, which is also considered to some degree cardiogenic shock, but is more of an obstructive picture, to be honest. Al-Kappa, which is what we call an anomalous left coronary artery from the PA. These are patients that have a coronary artery that's not coming out from the aorta, but really from the pulmonary artery. So when the PVR drops, typically at like 1 week of life, they start hypoperfusing their left ventricle and they can present with severe LV dysfunction. So a late presentation, you should always think of a ductal dependent lesion. So is there like something that's obstructing my outflow tract? Like aortic stenosis, coarctation, interrupted aortic arch, or is it something like Al-Kappa, for example, that's presenting a bit later that cardiology needs to see ASAP? Of course, myocarditis can be infectious, enterovirus, sepsis, other types of viruses like CMV, herpes, as well as inflammatory. So mothers who have like antibody that cross the placenta and causes ongoing inflammatory changes to your myocardium. Prolonged arrhythmias can present with severe LV dysfunction. There's a case on NeoCardiolab if you're interested in reading. And of course, managing the arrhythmia will be important, but sometimes they do need an extra kick by supporting their cardiac function. And then, of course, if you have metabolic issues. So we've seen a case recently who had lactic acidosis in the context of metabolic disorder. So anything that will increase your acidosis or intoxicate your skeletal, your cardiac muscular cells will obviously impact its function and how it's handling the contraction between the actin and myosin segments. So calcium, sodium, potassium, glycemic issues, lactate acidosis, all these things will also impact the cardiac function. And then you can have steel from the coronary system by fistula, sinusoids that can also impact perfusion. So these patients can present dramatically, or they can present more subtly. This is an example of a dramatic presentation, a 30-weeker with asphyxia, core pH 6.8, and you see it's almost an LV standstill where this LV is barely moving. And unfortunately, at 30 weeks, it's not a patient you'll be able to put on ECMO. So that's a patient you're going to want to decrease metabolic demand. It's a patient you're going to want to support the inotropy and trying to avoid having too much of high SVR, because then if you increase too much your LV afterload, you might even disturb the LV output even more because the LV is already struggling. So it's a patient you would consider like some degree of DOBU unless you're very tachycardic. Here, 140, it's not so bad. This is a patient you would consider maybe low dose epi, 0.02 to 0.05. When you start going higher than that, like at 0.1 to 0.15, you start having more of an SVR effect, so you have to be careful. And of course, milrinone is always the question. Milrinone is not an agent that will act like this. It's an agent that takes time to act. It's also an agent that will make you more hypotensive, and it's an agent that will renally accumulate. So if you have any of these three, like you need to act quick, you're hypotensive, or your kidneys are not working, milrinone is not a good thing for that. It might become a good thing eventually, but at that point, that's not what you need to start. You need to start something that will act on your function. If this kid has a massive left to right duct for some reason, I would be very surprised, because at this point, I think that the duct would support right to left function, a right to left shunt. But if this kid had a left to right shunt, dopamine would not be crazy, because your support inotropy, you're increasing your PVR, and you might limit the amount of left to right transductal shunt and promote the flow going to your system. But in that case, this kid had a completely right to left PDA, telling us that the RV was actually promoting the systemic compartment. So in that case, epi-dobu might be a really good choice. And when you have a full right to left shunt at your PDA level, you want to be careful increasing even further your PVR, because your PVR are already above your SVR. So if you're increasing more the PVR, you may start impeding on your RV function, and your RV is the one that's kind of supporting your systemic circulation at this point. If this kid was term, it's obviously a patient that I would start early on to activate my ECMO team to be aware of the patient while I'm trying to rescue the phenotype, basically. And then finally, I do want to mention that if this kid didn't have a super large duct, this is a kid you may consider maintaining the duct open as it becomes smaller. Hypovolemia, low preload. So there could be many reasons why some of our preemies or babies develop this. Always think about these things when you're seeing babies that may be low in preload. So if it's a low LV preload, it can be impacted by either the systemic venous return to the RA, and the RA going to the RV to the PA, and eventually feeding your LA through the pulmonary venous return. But it could also be because there's like a pulmonary hemorrhage. So obviously everything is bleeding in the pulmonary compartment and nothing is coming back to the LA. It could be other source of hemorrhage. It could be because you have very high MAP, and so nothing is coming back to the LA. And because of that, you're underfilled on the left side. You could have external hemorrhages, placental, cord accident, acute fetal maternal hemorrhage. Always think about that. The first hemoglobin in many of these patients will not be necessarily reliable, because they may, if it's very acute, they're not going to have time to hemodilute. So you need to trend a bit of your hemoglobin and understand if there's been an event of hemorrhage. Of course, if you see a case of sacrococcygeal teratoma and this patient has a rupture at delivery, this is not a case that you necessarily will need to immediately TNE, because this is the case that you immediately need to activate your transfusion protocol. And you need to have all these boxes coming and push with like syringes, because they're just going to bleed out until you're able to either embolize or close off this hemorrhage with surgery. But you could also have internal hemorrhages, intracranial hemorrhages, subgaleal hemorrhages, surgical traumatic events in the abdomen, shaken baby syndrome, if you're seeing babies that are coming a bit later from the emergency room, or even in your NICU if the baby has been unsupervised, unfortunately. Third spacing, preload dependency. There's many reasons some of our babies may have that. So we know neck sepsis, they have, systemic inflammatory response syndrome. Some of these effusion, high drops, ascites, lymphatic disorders, especially in Noonan, can have issues, or trisomy 21. Dehydration from renal tract. So, you mentioned, Ben, this baby, they are typically born with this tubulopathy of prematurity, where they're just not able to concentrate, and you sometimes are not even able to keep up with the fluid intake. And so you have to keep on increasing your TFI, and they can become quite dehydrated. And then you have syndromes like nephrotic syndrome, diabetes insipidus, post-obstructive uropathy, GI tract anomalies with congenital diarrhea syndromes that can be quite preload dependent. TTTS, you're going to have a whole class on this, but the receiver is used to receive a very high intake of fluid. And if you start restricting them too much in the postnatal life, they can become quite preload dependent. Extreme prematurity of high renal losses and severe hypertrophy of the heart is preload dependent, not necessarily because they don't have enough fluid intake, but because their ventricular cavity is so stiff. So that's an example of just a few clips of a patient with TTTS at 26 weeks. We were called for a baby that suddenly became very hypotensive, had pressures that were stable around 25 to 26 of mean, and then we were called because the mean blood pressure was 14 to 15, and they kept on climbing up vasopressors and inotropes, and they had given already 2 bolus of fluids, and when we came at bedside, they had basically this, obliteration of the LV cavity, these ventricles that are kissing each other. Look at the RA that is like super small. And then when you're trying to get an output, you barely get any kind of VTI. And so that's a case of severe underfilling due to low preload. This is an example of a patient who presented with high drops and antenatal intestinal perforation with meconium peritonitis. And we were called because this patient was on Norepi and, again, very hypotensive. And you can see that this kid has significant hypertrophy, and these walls and parasternal long axis are actually touching each other. And I don't know if you can appreciate in the apical view where there's almost no filling of this cavity. So we actually fluid resuscitated this baby, and Norepi was gone and within like 30 minutes. That's post-filling, where you can actually see an LV cavity and RV cavity, and now you can see an LA, an RA, and LV. Sometimes we use the IVC. The problem with the IVC in the first few days of life is obviously it can be impacted by the fact that the RV is still transitioning from the fetal stage. So it's always a bit more, stiffer than what you would expect in like an adult, for example. And if you're intubated on positive pressure ventilation, your IVC may have a nice caliber, and it doesn't tell you much if that's a patient that's underfilled. So sometimes in these cases, you may consider even like a small bolus, like 5 cc per kilo, and see if you're recovering your hemodynamics, especially if you have a suspicion of all these diagnoses I mentioned, and that your TNE is compatible with some of these findings, like kissing ventricles and empty cavities. Distributive shock. I find distributive shock may have sometimes a crossover with underfilling or hypovolemia, because in distributive shock, you can have a lot of venodilation. And because of that, you get a lot of pooling in your systemic compartment and the venous systemic compartment. And because of that, you have low vascular return. And that's why often the first treatment in distributive shock, like neck, is to consider giving some degree of vascular repletion. But really, definition is that you have a loss of systemic vascular tone with severely reduced systemic vascular resistance and maldistribution of flow. So you may have areas that are receiving nicely flow, and the areas that you actually would want flow are not getting the flow that you would want. So typically, these patients would be very hyperdynamic. They're typically tachycardic because they're pumping against nothing. They're pumping against no resistance. So think of a heart that you're transecting the aorta, and it's just spurting blood against nothing. So neck, sepsis, adrenal insufficiency, neonatal Graves syndrome, staphylococcal toxic shock syndrome. These are like kind of the classic. How do they look like? They become very hyperdynamic. You can actually see a cavity here compared to the previous, where you barely saw a cavity, but you can sense that there's a lot of hyperdynamicity to this heart. And often they even have like a very high output once a volume repletes them, if there's a component of poor LV filling. If you give a bolus, you'll often see that they get like output that are very high, like 300, 400 cc per kilo per minute, because the SVR is so low. So if you're calculating your output and you see it's very high, you're tachycardic, you have a hyperdynamic cardiac function, well, it's normal that it's hyperdynamic because it's pumping against very low afterload. The final big category, and of course, I didn't go into the complexity that some of these can be kind of crossing over, and that's where it becomes interesting in hemodynamics when you have, like, for example, a sepsis, and your patient may start with a phenotype that looks like low SVR, and eventually, as you increase your SVR with vasopressors, the LV dysfunction starts to uncover because your LV is basically now facing kind of relatively increased SVR, and maybe the infection is also affecting the cardiac function. So in these patients, you may need like kind of a mix of both inotropic support, like epi, plus or minus some degree of vasopressors, depending on the phenotype of your patient. That's why it's so important to reevaluate these babies. But obstructive shock is, the definition is typically an extra cardiac condition that's leading to impaired cardiac output. What we come in mind often is really that tension pneumo or their pericardial tamponade or constrictive pericarditis. You can have also pleural effusions that are causing issue. You can have abdominal compartment syndrome. So if you have a severe neck with terrible intra-abdominal pressure or gastroschisis that they try to reduce and now your intra-abdominal pressure is massive, You can put a probe and you're going to see your IVC all pinched and almost no blood flow going to your right atrium. Rarely in pediatric or newborn we'll see pulmonary embolism, but we do see a lot of severe pulmonary hypertension. And I talk about severe pulmonary hypertension with like a duct that's closed or very restrictive, and suddenly your RV is just not able to cope with the afterload. So that's a clear example of a pericardial effusion. So as you know, fluid is typically anechoic on ultrasound. This is kind of a subcostal / apical view. When it's circumferential, think that your baby is flat, lying flat most of the time or supine. So fluid will accumulate by gravity towards the back of the patient. When you start seeing this all around the pocket, it means there's so much fluid that's accumulating everywhere, right? Because this kid is not standing. This is very clear here that you see that the low pressure right atrium, you can see this flap kind of going inside during contraction of the atrium. And so this is a clear sign of tamponade. And of course, if your patient is hemodynamically unstable and has a large pericardial effusion, that's something you would need to address. You'll have a whole session on acute PH. This is an example of a kid who has a right to left duct telling you that the PA pressure is higher than the aortic pressure because it looks very restrictive, high velocity with aliasing through it. And you can see how this septum is bowing towards the LV. You can see that you can even see kind of the septum, the interauricular or interatrial septum kind of bowing towards the left atrium. And look how this left atrium looks underfilled because there's probably low pulmonary blood flow due to the high PVR, which is underfilling your LA, your LV, and eventually impacting your output too. So when you look at these very crude phenotypes, and often in hemodynamics, we're asked to look at these very acute changes, but also at the more subtle changes. But you really have to address the underlying cause to reverse the process. So of course, you need to support ventilation, oxygenation, and organ function. You need to consider antibiotics if you think that there's an element of infection that should be like, surviving sepsis campaign, start antibiotics as soon as possible. If you think there's a hormonal component, you need to correct them. Of course, if it's cardiogenic, you need to address the primary etiology of the cardiac failure. If it's aortic stenosis, no matter how much you're going to start inotropes, if you don't relieve the obstruction, you're not going to rescue your phenotype. So then that's when you have your cardiologist come in and support kind of the decision tree of how to treat these patients. What we see in hemodynamics are cardiogenic shock that are often related to functional issues. So like sepsis, asphyxia are the most common one. And so in these patients, you want to support your contractility with an agent that will support inotropy. So we mentioned it. It's typically either dobutamine that will start at 5 mics per kilo minute and then increase. The good news is that they have very short half-life. So it's something that you can adjust quite quickly and see relatively soon the effect. So, like a weaning protocol every hour makes no sense to me because they have a half-life of 5 to 10 minutes. And of course, if you have a lot of cardiogenic shock with low stroke volume affecting your perfusion, even if the BP is being maintained, if your baby is gray, if your baby is hypoperfused, like clinically with high lactate, I couldn't care about the blood pressure. Your kid is actually in tissue ischemia. So these are patients you're going to act at supporting the cardiac output, sometimes by acting on inotropy and then a bit on heart rate. That's where dobutamine helps a bit increase your heart rate, especially if you're low heart rate. And that's why it's very interesting in the HIE population where they typically will drop a bit their heart rate. And they typically already have a bit of high SVR because of the cooling process. But you also want to act on your metabolic demand standpoint. So decrease hyperthermia, make sure sedation analgesia is on board to avoid agitation, avoid oxygen consumption. Mechanical ventilation can help you decrease cardiac work. And in certain situations, if you have a component of high SVR that are contributing to the cardiogenic shock, you may decrease your SVR by decreasing afterload. So milrinone becomes very interesting in these particular patients. Chronically, in the management of chronic heart failure, that's typically something they'll consider. They'll consider agents that will decrease a bit the afterload, like ACE inhibitors or angiotensin receptor blockers. But that's for really patients who have like chronic heart failure. And at that point, our heart failure specialist from cardiology gets involved. Hypovolemia, of course, volume, antibiotics, anti-inflammatory, depending on the etiology. So hydrocort may be involved if it's like, you have like a storm of inflammation because of, example, HLH, which can present like this. Distributive, think about, component of low preload if there's venodilation and acting on the SVR with vasopressor. So our first line will typically be agents like norepinephrine, except that if you get to very high dose, you may have some effect on your heart rate. And at that point, you may consider vasopressin. More and more, we tend to also consider right away vasopressin, depending on the picture of the patient. Like example, the kid who's already very tachycardic, you may want to avoid putting an agent that may have some effect on the heart rate. Obstructive, you want to drain if it's something you can address. Tension pneumo, tamponade, pleural effusion. That's it. So these are the drugs. We'll have a whole session on pharmacology. I've put kind of the cheat sheet that I have here. I've never used methylene blue as an agent to increase SVR. It's been reported in one RCT, I think in Egypt or Turkey, and it's been used in the adult population. I think, we have a lot of other medication that we have more experience with to act on the SVR. But remember that these agents, vasopressin, norepi, phenylephrine, will increase your SVR, but will not necessarily improve your cardiac function. However, if you have really, really, really low diastolic blood pressure, that may really impact your coronary perfusion. And at that point, you may need to support a bit your diastolic pressures by having a bit of norepi or vasopressin once you rescued your cardiac function. I'll skip this. Of course, you often have mixed pictures of shock and hypoxia. So you can have a picture like this of severe biventricular dysfunction, where you have a left to right PFO, a right to left PDA. And at this point, you wonder, well, is this PDA supporting my systemic circulation? And what am I going to do? Am I going to maintain the duct open? Do I support anatropy? That's probably a case I wouldn't start pulmonary vasodilator because your shunt is completely left to right at the atrial level, even if you have a right to left shunt at the ductal level. So this is a kid I would treat with like combination of epi and maybe dobutamine or epimilrinone, depending on the BP of the patients. Let me skip this. This is the example of when you do have some degree of biventricular dysfunction, you can have very low biventricular output. So we've calculated many patients with the output. I think you can just appreciate how this VTI looks like very low velocity. So despite the fast heart rate, you end up with a patient that has very low LVO and RVO. So we spoke about inotropic support. We spoke about some of the systemic vascular resistance modulation. I'm going to skip this. INO in preterm, I'm going to skip this. Okay, I want to finish about something that you should all know, because if it happens at 3 a.m., you need to save your baby. So subcostal quick sweep, you already see that there's massive pericardial effusion. It's circumferential and there's clearly densing of your heart in the chest. If the kid is like chest compression and not doing well, and you're already a lactate of like 10 and, hypotension, intubation, the whole shit, like you don't have time to have cardiology come in and drive to the hospital in an hour to like save your baby. So you're an intensivist, you're at the bedside. So this is like a quick cheat sheet. It's also on the website under the effusion section. But basically what you need to do, and we'll have a technical workshop together doing this. Once you've identified that this is a tamponade and tamponade physiology, 30 degree for gravity to help. Identify the xiphoid process. You want to have your needle between 30 to 45 degrees, okay? See where you're putting your needle. Of course, you've already outlined that this patient doesn't have a dextrocardia, so you know kind of where is the heart within the chest in terms of position. At this point, because you're in tamponade, it's not, personally, I wouldn't use necessarily echo guidance to look at my needle, but if someone is there to help you, you can always have the echo probe to see where your needle is going. But in these patients, the sac is so overfilled because you're in tamponade that typically you're going to start entering your needle. And as you enter your needle, you pull. And as soon as you have backflow, okay, It means that, and you're doing this with like a vascular access catheter. So basically what you use to put a peripheral intravenous line. So you'll push the plastic part inside the tamponade, the pericardial sac. You remove your needle, and then you attach a second syringe to that catheter. And the reason is that as you re-expand, you want to avoid transpersing the myocardium. So similar to when you do emergency drainage of the lung, when you do an emergency tap, you want to avoid having your needle and just like pulling air, and then suddenly you create, fistulas. So here you have the procedure of how to do it quickly. It's a clean procedure because you're in middle of chest compression. If your patient is actually in middle of chest compression, once you've drained, typically around 2 to 3 cc is enough to remove the fluid that is causing tamponade. And the most common cause is obviously PICC line that's too far. And it's not because the PICC line perforated from the atrium or the superior and inferior vena cava. It's really because it's abutting along the wall of the atrium, and by osmosis, a lot of the TPN and a lot of the lipids are actually going through the myocardial wall and accumulating in your cardiac sac. This can also happen if you have cardiac babies in your unit, like post-cardiac surgery, post-pacer wire removal, post-septostomy, because there could be like injury to some of these structures. If you're doing transductal cath closure, you can have like injury to some of your myocardial structure, and you can have a post-cath tamponade event. And obviously patients who have like hydropic pictures or kind of chylus disorders or Noonan syndromes, lymphatic disorders, they may have also a risk of tamponade. Complications are rare, to be honest. The risks are obviously that you create an arrhythmia, that you induce a pneumothorax or pneumomediastinum, that you develop a hemopericardium, that you create a cardiac perforation, which is very rare if you do the procedure with the peripheral IV set. And you can have sometimes myocardial depression if you give medications or if you have been a long time without appropriate coronary perfusion. So if these patients are doing chest compression, it's a bit like pulse. You shouldn't stop chest compression once you remove the fluid. You obviously want to do your extra 1 to 2 minutes to get coronary perfusion. So that's an example. We had done a workshop at one of the centers in the periphery of our hospital, and you can see the PICC line, which is nicely into the right atrium. And then, they did the tap, and they got this TPN like fluid that was sent to the lab and was confirmed to be TPN with SMOF lipid. So shock remains very understudied. Of course, we need to reassess constantly our patients that have signs of hemodynamic instability. I hope I convinced you that BP is just one of the markers that's a component of perfusion, but you need to look at the overall big picture. And of course, looking at the bigger phenotype and how dynamic it is will help you better manage your patients. And that's pretty much it for this. I'm going to stop sharing. I'm going to stop recording, and we're going to open for questions.